You're listening to the Physio Matters podcast this month in association with Rehab My Patient, and this is session 78. Welcome back to the Physio Matters podcast. I'm still Jack Chew, and we're still in some form of COVID-related lockdown. Now, you might have noticed that there's loads of digital CPD all of a sudden, which is absolutely fantastic. We're really pleased to see and hear that. However, it has been noticed that quantity doesn't necessarily bring with it quality, and so we're pleased that many of you have been relying on us to curate your news sources in a sense, and that's really cool. We've also then created various different extra features, as you might have noticed, on the podcast feed, as well as across social media. Well worth me mentioning that you need to check out therapy-live.co.uk if you haven't heard about it. That's our massive digital summit online event, which is going to have 9 concurrent education streams for all things MSK, including a business stream, a pelvic health stream, MSK reform. I've got a stream discussing policy moving forward in a post-COVID landscape, that sort of stuff. But then there's also a load of really in-depth clinical content, upper and lower limposiums, one of my favourite puns I've come up with yet, and then the spinal pain, exercise rehab, physical therapies, talking about the sensible and contemporary use of adjuncts. Absolutely loads there, and it's absolutely free at the point of use. Now, one of the things that we've been asked a lot of is, are the recordings going to be available after the show for those that either can't attend or want to watch other streams that they're going to have missed? It's taken a bit of working out how to do it, because you can imagine it's an awful lot of content that we're having. It's going to be over 70 sessions of education. We have found a way to do that, and it's with our partners at therapistlearning.com. It's very complex, but we are going to manage to do it, and we are going to be able to get you that in a format that is both downloadable and streamable, which is going to be great. It will be at a fee, and so if you want to get the content free, you need to turn up on the day, therapy-live.co.uk, 26th of June, all day. But you will be able to access the content if you miss anything or there's other sessions you want to catch up on. That will be available to you, and we will make that available very soon after the show. We've come up with a mechanism to be able to do that, which is great. A little more on that. We've got the Therapy Live newscast on the evenings of Mondays, Wednesdays and Fridays. We're basically doing the announcements, going through, speaking to the speakers about what they are planning, what else they're looking forward to, and just having a bit of a chinwag, which has been a lot of fun. So check out the spinal pain and lower limposium streams that have already happened. We've got one tonight on pelvic health. I know that this podcast goes out after this stream, but basically they are a lot of fun. So check out the ones that have been recorded, tune in live and ask questions of the speakers and tell them what you're looking forward to and what you want from them at the Therapy Live event. So they're going to be on Monday, Wednesday, Friday, 8 o'clock BST in the evenings over on Facebook Live with the speakers for each of the 9 streams that we have available, which is very exciting. Congrats to podcast sponsor Rehab My Patient on the success of their new telehealth interface embedded within their exercise prescription software online. So it's all accessible on the cloud, and then you therefore can get in contact and then feed your patients quality rehab instruction over their new interface. Really, really successful. Do check that out. rehabmypatient.com/Physio Matters for your free trial as a valued listener. Today's podcast is going to be up there with the very best I think you've ever heard. I certainly think it's up there, and it's because I think I'm often having conversations with some of the best and brightest in the game on this show, but it's often the first or second conversation I've ever had with them, and I'm aware of their work, but I'm trying to tease out, and I don't necessarily know how they present material or what they are and aren't into in terms of styles of questions to get the best out of them. Whereas these two gents, we've got Brad Neal, who has been on the show before and a good friend, and then Simon Lack, who I've known for a long time, consider a friend as well, who hasn't been on the show before, but also is just, I've been paying attention to his work as well as seen him present many times. And so it felt like the conversation could flow and we could get really stuck in, and I could hold them to account on clinical examples. It's also on a pathology I've seen so much of, especially recalcitrant cases and second opinion work that we do a lot of. And so it was something that we really got us teeth into. I hope I did it justice. I know they did. They were absolutely brilliant. And thanks so much to Brad and Simon for their time. I hope you really enjoy this. This is PatelloFemoral Pain with Brad Neal and Simon Lack. I'll see you at the other side. Delighted to be here today with two of my favourite thinkers on all things kneecaps, Simon Lack and Brad Neal. You've had Brad on the podcast about ITB pain historically, as well as both of them been involved in speaking in public and thinking in public about this as a topic for many years now, particularly whilst studying for their PhDs, both of which now, Dr. Brad Neal and Dr. Simon Lack, of which they've then studied this to high heaven. So they should know plenty about it. So it sounds about time we got them on this long-awaited podcast to talk about patellofemoral pain. Could you introduce yourself to the listeners, particularly in terms of your roles as this stands? Starting with you, please, Brad.
Yeah, sure. So clinically, I work for Pure Sports Medicine, as does Simon, where I have a split role where I work as a clinician, seeing patients sort of 60, 70% of the time, and then have a head of research title alongside that, kind of loosely based around aiming to ensure the optimization of evidence-informed medicine across the company, and then also hold a research fellow position so that I can continue researching as a postdoc within sport and exercise medicine at Queen Mary, University of London. And you'll hear those same words from Simon, just with slightly different words attached next.
Quite the partners in crime. Anything you do differently, Sam?
Yeah, so I lead the MSc program in sports and exercise medicine at Queen Mary, which obviously, given the current situation, is having to undergo some significant changes and rethinks as to how we might deliver all of that remotely, and trying to ensure then that the people who are coming on and studying with us are getting a lot of those sort of practical skills as well as the theoretical knowledge. So there's a lot of discussion around teaching and teaching practices at the moment, which is where my role kind of predominantly sits from an academic perspective. I still do some research activity in postdoctoral roles with Brad, and we're currently undergoing some studies together with that. And then what else do I do? Yeah, so then I do my clinical role in Pure Sports Medicine with Brad, as he mentioned. And I also do some work with some scholarship athletes at the University of East London, which is another sort of arm to what I get involved in from a clinical perspective.
Certainly sounds busy enough, boys, so fair play. Okay, so one of the things I wanted to talk about, and when we're doing a podcast, particularly in and around a condition or an umbrella term, is the sort of terminology is important. But before we get stuck into the weeds of what to call it, I wondered if we could sort of get your take on what it is. What are we meaning when we say patellofemoral pain?
I think that we've discussed a lot about the challenges of the diagnostic challenges of patellofemoral pain, and we may go into that in a little bit more detail. But in essence, what we're dealing with here is pain that originates at the front of the knee, often described as being deep to the patella or underneath the kneecap. And the critical part here is that it's in the absence of other concomitant or intra-articular pathology within the knee, and I think that's such an important differentiator. The courses that Brad and I do and deliver, we spend a great deal of time now actually making sure that the assessment of people is thorough, such that we can be confident that other tissue isn't driving this sort of nociceptive cascade from the knee. And that, is it fat pad? Is it menisci? Is it some aspects of the retinacular? Is it the tendon? And when we're confident that we're not seeing those other pathologies, that's when we're more confident in arriving at this diagnosis of patellofemoral pain. It's insidious in onset, so it's not often associated with a traumatic episode. It's often quite debilitating, and it inhibits these key functions that we talk about constantly and hear and see and read within the literature. Things like when we're loading the knee, obviously climbing stairs, sitting for prolonged periods of time, squatting, running, etc. So you're arriving at the diagnosis of patellofemoral pain when we're happy that we've excluded other differential diagnoses, and that when we've got this insidious onset of retropatellar or anterior knee pain that is aggravated by loading activities.
Some people will be surprised at the differentiation and consider fat pad, for example, and retinacular issues, and maybe even some would extend into, say, tendons as being part of the wider syndrome of what is being considered. And so you're clearly teasing that out for good reason. Do you think there is a strong case, or where is the key fault at the case for lumping others in?
Yeah, I mean,
we can go to Brad on that, I suppose.
Yeah,
Let's just draw you in on that, Brad.
Go on.
Yeah, it's certainly a challenge. When I'm talking to a patient, and this is you'll see material coming out of our group that is patient facing, very much just talking to kneecap pain. I think that's an appropriate term to use for patients. But in terms of when talking to other clinicians or when we're delivering a diagnosis to a patient, the main reason that the sort of wider research groups have this consensus that we should probably drop the syndrome qualifier. Normally, when we stick that on the end of something, it normally means that we're not entirely sure what we're dealing with, and as a result, it could be this rather large umbrella. Whereas, at least from my perspective, as I review the literature and I see patients, I can normally be relatively comfortable that I can exclude, for example, patellar tendinopathy, isolated fat pad irritability, kind of joint line pain, whether that reflects a meniscal problem or an osteoarthritis problem, the onset of symptoms as a result of trauma or not. I'd like to think that whilst no diagnostic process is perfect, and that's probably a path we don't necessarily want to go down so that we don't lose focus, from a diagnostic and terminology perspective, I think we can be relatively comfortable that we can exclude to the point where we can be as comfortable as we can saying, I suspect your pain is emanating from your patellofemoral joint rather than from other structures within your knee.
And so what is then being considered within the diagnosis of patellofemoral pain? Because arthritis, say anterior compartment arthritis, particularly of a lower grade, would certainly be within that umbrella still. Are there any other things that, and is there an upper limit to that with OA? And also, are there any other things that are considered to be part and parcel of PFP?
Well, the OA question again is challenging in that there are groups all around the world hoping to get to a point where we can nicely say this is our patellofemoral pain box and this is our patellofemoral arthritis box, and we're definitely not there yet. If you look at most studies, the cutoff is normally based around age, which obviously isn't perfect, but it at least gives us something to work towards so that we can't be accused of comparing apples to oranges. And I think certainly from my point of view, it's where the various imaging modalities can offer us a little bit of greater clarity in trying to separate out someone that has patellofemoral pain versus patellofemoral arthritis, although you could probably make the argument that may not matter because from a management perspective, we're not necessarily going to look to do anything that's grossly different outside of a few maybe sort of N equals one example. So in terms of what does come under the patellofemoral pain umbrella, I would say it's probably easier to think about stuff we're trying to exclude. So if someone's got isolated fat pad pain, I'd certainly take that out. If someone has patellar tendinopathy or patellar tendon symptoms, I'd look to take that out. If someone's got isolated joint line pain or localized ITB symptoms, they're the things that we're looking to take out. And we're doing that based around nothing more really other than what they tell us, the location of their symptoms and the aggravating factors. For example, it's fairly rare to see patellar tendinopathy in a recreational runner, but it is pretty common to see someone with patellofemoral pain that is a recreational runner. So if the symptoms are in a similar location and we have some imaging which confirms or negates tendinopathy or perhaps something going on in that compartment, that's how I would look to separate the two out.
Yeah, no, fair point. Anything else to add on that side of the conversation, Simon?
I suppose my only additional thinking really on top of where I'm sort of interpreting you are going with that, Brad, is that the management can, or like you were sort of saying really, is the management going to massively change dependent on what we're seeing? And certainly I think that then comes down to this aspect of deficits, and this is where your assessment around deficits becomes critical and understanding where this problem kind of sits. So and the assessment and the information that the assessment gives us is so important to inform your management planning and so on. And the diagnostic label. A diagnostic label is something that's useful, but often it's useful because it's a way of communicating it back to the patient and helping them to understand what's going on, and then also to tie that in, that diagnostic label, but with a specific set of problems or deficits that we then need to target, and that we structure our planning, our management planning around it. So
I think that often guides people, doesn't it, where they can recognise that there would be a very different management to a patella tendinopathy, or particularly overtly sore fat pad, where they're needing to try to find a way to decelerate or block terminal extension is going to be different to the way in which you'd manage PFP. And so that sometimes offers a guide where, you want to be careful not to lump things in if you're going to then completely compromise the management and care, and you end up almost being so vague on both sides of it otherwise. So that makes
and the way in which they read around it, the way in which they understand it, which we're appreciating in so much more in terms of the value of it, how any given patient understands the problem that they've got, understands the rationale for the management, for the approach that they're being managed through, if you like. That comes into a part of where the role is of diagnosis, but it's got to be linked with an identification of where there are specific treatment targets, and that's why we're managing you in this particular given way.
What do we know about what variables do influence this, and especially want to then talk about the things that are managing or controllable and otherwise? Because sometimes that's really important to patients. How much of this is just damn poor luck and somewhat inevitable, and how much of this is the many different controllable variables that actually can then give us treatment direction?
I think to a degree you're touching on what things are known risk factors, right? And what things are known associated factors. And Brad and I have just fairly recently completed a systematic review that looked at trying to identify risk factors. And Brad, you're probably better placed as you led on that to sort of fill in the gaps that I'm about to leave out. But in essence, the evidence isn't particularly great. You'd be not surprised to hear with regards to predicting of the onset, so risk factors for the development of patellofemoral pain. And some of that, I suspect, is because it's really hard to get after, and as we probably all suspect, and the evidence would suggest, is that it's seldom down to one variable alone as to why any one individual will develop symptoms. And certainly then when you clump them all together, the noise to signal ratio is just not going to work out in your favor to being able to arrive at, oh, well, it's that, and therefore we'll just treat that particular variable of quadricep weakness, and lo and behold, no one will ever get patellofemoral pain again. I mean, wouldn't that just be lovely? But that's not the world in which we live. And so where we went with that paper was to start to try and divide populations down a little bit, because actually the evidence is building enough that we were able to do that. And it separated it between some runners, I think, and the adolescent group and the military group. And there were some characteristics that came through on this, which was, and I mentioned quadricep weakness for a good reason, because actually the one of the variables that was fairly consistent in terms of predicting the onset of patellofemoral pain was quadriceps weakness within a military population. And then there were some other variables that emerged beyond that. But yeah, the evidence for predicting the onset is scarce, really, but there is some evidence out there, and certainly that evidence is building, and that's because prospective studies are hard to do. But they give you some insight into what's going on. But what I think almost they do tell us, even though the evidence is sort of not satisfactorily sort of broad and all-inclusive, is that to pin it down to one single variable, I think there's enough studies there to say to pinning it down to one single variable, that's not going to wash. And the route forward is to appreciate the complexity of any musculoskeletal complaint and do your best to try and factor in multiple variables in order to understand it better.
Sure. I want to just invite you to potentially add to that then, Brad, especially with that recent work.
Yeah, so I think there were two big things really for me that came out of that paper. One being that, as Simon said, we've got a very limited understanding of what variables precede someone developing patellofemoral pain. And I think it's kind of a good time to talk around what we mean by a risk factor, because some people get quite prickly around the word risk, and I think it's key that we frame it as that. It's a risk. It doesn't mean you're going to get it. It just means your risk of developing symptoms is heightened relative to someone that doesn't present with that variable. But when we do these types of work, and in this case a systematic review where we attempt to pull multiple data sets together, we're at the behest of what has been measured. We can only pull what has been measured. So, as Simon alluded to, we identified that low quadriceps strength is a risk factor for the onset of patellofemoral pain in military recruits. And that's what was measured. That's what we meta-analysed. That's the output that we got. That's not to say that every military recruit with weaker than average quadriceps is destined to get PFP and shouldn't enter the military. The way I present those data is that, let's say you're working in a situation where you work in the military and you have a fresh batch of 1,000 recruits every year, measuring their quad strength and aiming to separate those with weak quads, perhaps to do something a bit different in the early phases of basic military training. It's probably sensible. And that's the way I would present that. But then if you look at what we identified for the adolescents, we identified that higher than average hip abduction strength was also a risk factor in that group. Now, it doesn't necessarily make sense if you think about it in black and white terms on paper that someone with stronger hips would be more likely to get patellofemoral pain, even though we're now talking about adolescents versus standard adults or military recruits or runners. So you've then got to try and think about the next layer, which is, well, it wasn't measured, but why have those adolescents got stronger hips? The argument that we made was that chances are they're probably more active than their peers, and it might be that that's why their symptoms came on. But what reflects that, what was measured, is the strength of their hips. Now, that's very much a theoretical model. And if you look in that paper, which is published in BGSM, we built what's referred to as a causal inference diagram for these two variables and tried to show how everything potentially fits together. But at the moment, it is very much a theoretical model. And our recommendation for future work was that we need to try and measure more variables, particularly variables that perhaps link together, like activity level and muscle strength, so that we can truly understand that particular cohort's journey from no symptoms to symptoms.
One of the things I'm going to be brave enough to do is try to ask you, if needs be, to take off your researcher hat and put back on your clinical hat. Now, I know that both of you wear both at the same time and do that well, but in this instance, you hopefully you'll understand from my question, is that if we think about a typical participant who might be for a trial, or in this instance then also a patient that might present, I wondered if you could give me your sort of take as to what factors affecting them. Let's say that you were seeing them before they were injured, this is an asymptomatic person of a mature adult skeleton. They're just 20-year-old. We can make it either gender, I suppose. But just generally speaking, what characteristics broadly, that can be morphologically, biomechanically, biopsychosocially, whatever factors affecting it, having seen many people both in clinical circumstances and in research, do you feel are sort of your take on the dispositions or the likelihood, if you had to line people up, even though that might not necessarily show in the data yet?
I mean, yeah, if we can...
Because I think the honest answer is we don't know, do we?
Yeah.
Like, we just don't know. Like, there are just too many things at play. You can't derive causation from association. We know that, and that's a dangerous world in which to get in. So as a clinician and you're seeing a patient coming in with these morphological changes, or you see some weakness, or you see a movement pattern, or you hear the story of them having done too much too soon, well, we sort of, that's a patient that is presenting in pain, and you can make some inferences as to what you think may have resulted in them developing those symptoms, because there's certain things that stand out the most predominantly in their history or in their physical examination or the like. But if you're looking at it from a purely sort of evidence-informed practice route, we don't know beyond what we've just talked about in terms of where the evidence sits with a military cohort or with an adolescent cohort. Beyond that paper largely came up stumped, didn't it?
Because one of the things with this, look, you're not suddenly going to get me thinking that I'm going to bait you into saying correlation equals causation. But sometimes correlation does mean, oh, look over there, it might be interesting. And so I was sort of trying to play fast and loose with two, esteemed researchers I know. So maybe I'm being too cheeky, but I just wondered if you had any sort of clinical takes where you're like, oh, we don't have the data yet, but fundamentally I'm noticing this pattern. Now, if not, that's not a problem, but I was trying to bait you in that direction beyond the data.
I think that there is some stuff there that we could look towards, particularly population specific. If I suddenly found myself where the British Army came along and said, have this big bag of money, here's our fresh crop of basic infantry recruits, we want to be as best prepared as we can, and we want to try and reduce the likelihood of this cohort of recruits developing patellofemoral pain. I'd measure their quadriceps strength. And if I had enough money, I'd do it with an IKD. If I didn't have quite as much money, I'd do it with a handheld dynamometer. And I'd do my best to separate that group out and say, these are a strong enough group. They'll probably be all right. Do what you normally do. This group here, they're definitely lacking. I'd suggest we do this strengthening program for X number of weeks before they kind of try and then rejoin their peers. And I think we can do that with the adolescents as well. I think we can, again, if I found myself in that situation where a school said to me, we've got a lot of good athletes here, we want to try and make sure that they don't get, their training's not inhibited by the onset of patellofemoral pain, what should we do? I think looking at some measurement of the amount that they do needs to be kind of in under consideration. But it's an interesting question because one of your staff members called me out the other day for having a PhD in caveats and constantly saying maybe we don't know the answer to that question, and I found it rather humorous. But the reality is, I am always a bit perturbed by how confidently some people talk around certain variables as being the solver of the problem. There was a particular slide I saw the other day for a running conference that went on that talked about running gait and biomechanics being a really small piece of the puzzle for injury onset, which I would completely agree with. But then other variables were stacked up, with great confidence saying these things do increase your likelihood of getting a running injury. And it was things like poor sleep, the amount of training you do, your volume, your intensity, etc. And I'd love it to be the other way around, but we just haven't got the evidence to say that. I understand the theoretical link, and there's certainly some retrospective data to suggest that when someone has pain, generally, their sleep is affected, various other variables, but to put them out there as variables that cause injury, we're miles away from being able to do that. And the people often, in my experience, the people that are very quick to dismiss the evidence that we do have, and there are some data which suggest that biomechanics might get you into trouble. We can talk about that if you want. But the people, in my experience, that are very quick to dismiss those data are also the people that then put these other variables up on pedestals when the pedestal's not even in construction yet. We just haven't looked.
They're getting away. I think one of the reasons that they're getting away with that is because you've got certain things that they feel that they're able to be more dismissive over than we would like, is partly because they've been well studied, whereas you've got sort of younger variables in a sense that these aren't things that have been, because the work's not existent, they feel more comfortable to float it because it hasn't been refuted. But that's only a time mechanism thing, and also there's other factors that are less studied that they wouldn't ever lump in. So it just is a way of sort of tickling people's biases, I guess, to stack up things that have been less studied that might hold up theoretically or in a different cohort or in a different body part, different pain pathologies and presentations. So I do agree, and that is a frustration of mine too, that there's the lack of consistency and sometimes almost some hypocrisy as just being a clever way of sort of floating someone's biases. But in PFP, especially, we think about comparing this conversation to when we were even talking in episode 1 with Lee Harrington. You know, it's an interesting thing for us over 7 years of doing podcasts is the fact that we have more data. It doesn't necessarily mean we've got the answer yet. That'd be nice, but generally speaking, we move forward. I wanted to bring you back in, Simon, to start to visit that conversation about biomechanics, because we've talked about factors affecting, and we're here in a situation admitting the fact that we don't have those, you know, we don't have a smoking gun in that direction. But that's one of the most contentious things sometimes is there an understanding of how someone moves, particularly when we delineate it by category, say adolescence, running, whatever it might be, or even on a particular test. Do we know that there is any disposing movement patterns or behaviours that then mean that someone is more or less likely to get PFP?
Where are we kind of going with that? I suppose you're asking about kinematics or biomechanics. For me, is a bit more of a broader term. So, you know, the kinematics, which is the observable pattern of somebody's movement. Is there some good evidence to suggest that is a causative factor? No, we come back to what we were just discussing. No, there isn't. But are we observing particular movement patterns within a population of people who have patellofemoral pain against those who don't? Yeah, I think that we're confident to say that there are observable differences in terms of movement patterns, and whether those are a consequence of pain or whether they were the cause of the pain is the thing that's open for debate. But what we have certainly seen, and sort of Brad has looked at some of this, as have other authors, you know, when we're changing known components of that movement pattern, we are seeing and observing a change in people's symptoms. So, you know, again, we can look at the association between that movement pattern and symptom in so much as by proxy, you know, you're getting a change in pain when you change that movement pattern. So there's some good rationale for going after observed movement patterns to try and modify pains. This for me comes back down to understanding and the whole premise of what is a clinical assessment of you being in clinic. You've got an individual who's come to see you because they've developed this symptom of patellofemoral pain. You effectively being confident in arriving at an endpoint of your assessment, subjective, objective assessment, and saying, okay, for me, the way in which you're moving, the way in which you're controlling movement, the muscles that are contributing perhaps to that movement pattern, but actually it may not be that those muscles are contributing to that movement pattern. It could just be that the muscles themselves aren't demonstrating the capability of moving or completing that task to that number of repetitions or at that load, etc. Is the element, as I look at it, that is likely to be the best explanation for why your symptoms have persisted or why you're coming to see me with this given particular pain complaint, if that makes sense. If you follow my thread, it's like, you know, that subjective objective examination is informing you as to whether you think this particular movement pattern is the thing that's contributing to either symptom persistence or potentially to symptom development in the first place. And that's clinical reasoning for me. That's what I love to teach. That's what I love to be involved in, trying to understand better. That's where I want this evidence to be informing, because we know that clinicians are faced with a complex task of trying to merge all of these elements together to arrive at a meaningful route forwards that they can inform their patients about and manage appropriately. And so biomechanics forms one of those, whether that's dynamic knee valgus that you're observing on their symptomatic knee compared to their other knee, that you're doing it with two-dimensional video, or whether you're just visually observing that during a single leg squatting task or during a running task or other functional task. And that, you know, you may well try to modify that. And if you're observing some change in symptoms, then again, that gives you some indication that that could be something that we want to try and address. And you want to be exiting that deductive reasoning approach, kind of going, that's what I think is the predominant maintainer of symptoms, and that's what I'm going to go after. And I think that that's a really important place to end your initial assessment at, and in order to formulate your appropriate management plan.
Yeah, I think it's sensible for that conversation, that question to have been taken towards understanding symptoms and how those things are going to be integrated within a clinical reasoning model. Absolutely. I suppose one of the reasons for my question is that it is often wondered if there is any sort of biomechanical variable. You're right to say that that's vague, but be that kinematic factor or kinetic variable that's measurable that we could understand as a predisposition, particularly independent of symptomology, rather than thinking about its modifications or it offering a potential avenue for treatment and care. So I suppose, Brad, if I can just try, because we're definitely going to wade into those treatment variables, because I think that's where a lot of the interesting conversation is. But if I just try and pull the brakes just briefly and say, give an example then for someone's attending clinic for a shoulder pathology. I know this is a bit far-fetched, but sod it. This is someone that's then...
They wouldn't be seeing me.
Well, someone was seeing you. That's a good point, yeah. They're coming to see a boring generalist like me, and they've got a sore shoulder. But for some strange reason, partly off the back of this conversation, I'm in a mood to do some movement screening for some reason today. They've got a shoulder problem, but it just so happens that I'm interested to see and potentially measure on a new piece of kit that we've got. I want to see them do, say, a single leg squat, or might be running or a drop land or whatever it might be. But I'm just meaning that, are there certain factors that we would find, bearing in mind that this is someone that's otherwise got no injury history, by the way, and no symptoms within their knee, but is there anything that would be or could be measured in that instance that might well mean that we look on at that patient and I either think or even articulate that I might feel like I might see you in the next few years with PatelloFemoral pain? Is there any variable that we can understand that may well, as an independent variable as well, for that person to potentially represent?
No, I think the answer to this question's fairly straightforward, and it's definitely no. We have very limited prospective data which suggest any mechanical variable, be it kinematic, kinetic, EMG, etc., predicts the onset of pain. You can almost count the studies on one hand. There's one prospective cohort study from Brian Noren's group which suggests that females that present with greater hip adduction during running are at a higher risk, but the paper, purely because of the number of participants that became symptomatic, has a very high risk of bias, purely because the prevalence of PFP or the incidence, I should say, in that cohort was very small. There's a similar paper from Michelle Bolling's group, which looks at drop landing in the military, which will suggest that internal rotation of the hip is a risk factor for PFP onset in military cohort, and it's the same cohort from which the foot pronation data come from. But if you look at our risk factors systematic review, you won't see any biomechanical data in there. And that's purely because we only included variables where we could pull data together. So at least 2 studies needed to have looked at a variable so that we could pull those data together, give you a singular outcome. And for all of these biomechanical variables in prospective analysis, they're all in isolation. So the answer to that question is really straightforward. The way I think about this, and the way I would look to explain this to someone, is we try and separate out biomechanics, particularly into kinematics and kinetics. So the geometry of movement and the forces that result in that geometry. And from a clinical practice perspective, we pay way more attention to kinematics because we can either see it with our eyes or with our 2D camera or with our pretend 3D system that some people have in clinic, right up to what we have in our lab, which is a 3D motion capture system. But the reality is the influence of biomechanics on pain can't be separated out. If you can almost think about it like a tree. If we have joint stress being the variable we're interested in, joint stress being a simple composite measure of the amount of force that goes through a joint relative to the surface area over which that force can be absorbed, we're interested in kinematics, particularly at the patellofemoral joint, because we've got a really good understanding of what goes on. We know that if we adduct the femur or internally rotate the femur, we see lateral translation of the patella, which will affect the geometry. And we know that if people are dysplastic, their geometry is already affected. So these variables potentially have a larger influence. But all that's changing is the potential geometry. If you don't load that knee, if you don't put any force through that joint, it doesn't matter what the surface area is. So unless you're measuring both, unless you're looking at kinematics and kinetics, you're never going to have the answer. And it's why, I often hear people present the Kenyan marathon runner who, Prasaya Jeptu, I believe her name is, who runs with a very unusual gait and has a really valgus knee. And they say, well, why doesn't she have pain? And, the answer is, I've got no idea, because I've never seen her, never assessed her. Stop asking me stupid questions. But her kinematics are quite clearly above and beyond normal, for want of a better term. But the level of force going through that knee is probably relatively low, because she's an elite marathon runner with a very high step rate. She's probably 35 kilos after she's been out in the rain. Unless we're looking at all of it, hopefully you're still following me, biomechanics will never give you the answer. Because we can't do that in clinical practice, I think that's why these data become very easy to dismiss, when actually just because they can't help you predict who gets pain doesn't mean they can't help you treat someone.
So does it, because some people would hear that and therefore want that to be a nail in the coffin for asymptomatic movement screening, and then those that recognise we want to know all the things would say that actually movement screening, if maturely interfaced within a clinical reasoning model in an environment in which that feels appropriate, say a team that you're working with in which you can do those sorts of things and have those things on record, not make any inference or change their behaviours because of them, but that would still be useful data if it's informing your clinical reasoning. But those two outcomes are very common from people some people that want to just say, as soon as I hear about movement screening, I just think of pseudoscience. And then others that say, well, no, the way I'm reading this information is that as long as it's not the only thing we're using to inform things, it can actually be useful for me to know.
I think for me that loops back around to where we were at before, which was about the fact that one single variable isn't going to be a variable that we could rely on or hang our hat on solely, that it's about how we're integrating those movement mechanics with a volume understanding of how much they've been doing, with their strength, with these other components. That's for me the next meaningful step forwards in terms of understanding an individual's given risk, really. It's about really ensuring that we're not satisfying ourselves by just saying there's this one variable and we look at that and we'll understand it all. It's about integrating all of these things together.
Yeah, and it's certainly, for me, nail in the coffin is too strong. If we look at all of these prospective studies, we're thinking about how we get to an outcome, and in doing so, we're attempting to measure an exposure, whether that's hip adduction, whether it's low quadricep strength, etc. But unless we measure how much of that exposure someone gets, we're a long, long way from getting to the answer. So if you think about areas in society where we are quite comfortable that one variable predicts the onset of another, let's think about smoking and either heart disease or lung cancer. If we were looking to make widespread sort of policy changes or policy implementation off the back of only a handful of studies, society would probably say no, and rightly so, arguably. So if we think about biomechanics or movement screening, etc., I don't think there's been anywhere near enough work done yet for us to be able to say there is a clear absence of effect here. We've measured this thing until the cows come home. We've not found an association between a variable and pain onset. Let's put it to bed. The reality is prospective studies large enough in order to answer these questions with a robust enough methodology cost a lot of money and take a lot of time. So as a result, we don't have a huge amount of them. So there's still definitely some rationale and arguably potentially some benefit to continuing to look down that avenue. But have we got enough at the moment to say that we can use a movement screen to predict someone's likelihood of getting PFP? Absolutely not. There's just nothing there.
Yeah, absolutely. I'm well aware that if I don't move on past this line of questioning, then you're probably both going to hang up on me. We'll definitely move to understanding a little bit more about the pathology, as well as then trying to get towards this sort of where the indications for treatment and care best inform us and from the evidences at the moment. So could one of you give me a bit of a lowdown? I think we'll bring you in, Brad, on what the lowdown is as to what the natural progression of PFP is, because there's so many myths and misconceptions around that that it's probably worth us just visiting what its typical sort of present, the way that it progresses and behaves over time is under our research and clinical understanding of it.
Yeah, and I think the biggest misconception that it's good to try and dismiss, I think, particularly for the audience here, is that it's not a self-limiting condition. You know, if you look at the work that's been done, particularly starting with the adolescent cohorts, that particularly Michael Rathlathat in Denmark contributes to a large amount of that research, right through to the work that Kay Crossley and others do in patellofemoral OA. If we sort of think about it on that continuum, it doesn't seem to go away on its own. Sort of left unmanaged, generally speaking, the natural history here is quite poor. It's unlikely to be something that gets better on its own, unless you see, I guess broadly, you see two types of patients, really. You see patients that only get pain when they run, for example. And if that patient chooses to stop running, arguably their natural history is quite positive, as long as they're psychologically willing to make their peace with the fact that they can no longer run. Whereas if you see patients who get more day-to-day symptoms, pain when they ascend and descend stairs, pain when they're doing various things in the gym, pain with prolonged sitting, for example, they're the group for whom natural history, I would say, is certainly significantly poorer. And left unmanaged, chances are these people are going to have pain for a prolonged period of time. And if you look at the prognostic studies that have been done, there's some systematic reviews out of UQ, and again, some of our colleagues at Erasmus as well. Ninka Lankhorst has done a very nice prognostic systematic review, kind of looking out towards sort of the 8 to 10 year mark. And, you know, generally speaking, very few participants seem to get completely better. Large group of people seem to get somewhat better, and then there are a group that don't get better at all. And the reasons behind that are going to be multiple and multifactorial and likely to be individual, but certainly left unmanaged outside of a very small subset of patients that only seem to get symptoms with one particular activity. I think it's important to say that the natural history is pretty poor.
Simon, how good are we at treating patellofemoral pain, do you feel, on balance?
On balance, I think.
I mean, we're very good at it, aren't we? But
yeah, obviously. Look, I think in the short to medium term, we've got some good evidence, and we've got some good interventions that can have a very positive and meaningful effect on individuals. The challenge that we're faced with is that we are finding, and the evidence is suggesting, that in the longer term, these positive effects aren't working for the vast majority of people. Like, we're getting people better. Like, I don't think we should be negative here. On the whole, the interventions that exist are getting people better, and we should continue to encourage and promote that aspect of it. You know, intervening in the ways in which we are, with exercise therapy, with appropriate management of individuals or education around individuals, volume and frequency, and informing them as to the role that plays, and the like, do have a positive effect. I think we could very quickly get into this whole negative thing of, oh, we're not doing stuff that's good enough, etc., etc. We are. What the evidence would suggest, and certainly, you know, we've observed this with the cohorts that we've looked at, even within Pure, etc. There's a percentage that are fully resolved. Lovely, thank you very much. There's probably the vast majority of people who are better, but they're not fully resolved. And then there's a group of people who are not better. And for me, I'm always thinking, okay, well, we've got this group of people who are better, but they're not fully resolved. Why is that? What is it that we're not doing within our management approaches, within our long-term support or advice that means that these people are getting better in that short to medium term, but they're not necessarily getting fully resolved or as good or as better, if you like, as we'd like them to be. And that's the challenge. That's where I see as being the research challenge, the clinical challenge, the clinical informing research, the research informing clinical challenge, really. And that's what gets me out of bed in the morning, I think, with regards to this. Yeah,
absolutely. That's where the interest is, and it's why the interest will persist. It's not as if you guys have come to a conclusion that's then meant that your fire stops burning, because it's actually been solved. So yeah, Brad, on that question then, with regards to sort of the core care and core treatment of it, then what does that typically look like in an evidence-informed perspective?
Individual for the individual cohort or the individual patient would be my answer.
We definitely don't need to unpack. We could potentially give some case studies. I don't think we're going to necessarily have time, but no, in this instance, you feel free to answer on a cohort by cohort basis, whatever category you feel is a simpler way of answering that question. Like, what does it look like in terms of the giving examples of treatment direction for particular classic cases that present?
I mean, I think if we, just so that we don't forget about them, I think if we separate the adolescents off, a very easy thing to say is that we should be managing particularly young adolescents in a very different way. So from up until we start to get into the late teenage years, typically younger adolescents, if you look at a lot of Michael Rathlef's work, certainly don't present in the same way as adults. They don't generally show us certainly muscle strength deficits. They don't tend to demonstrate the same movement patterns as adults. And as a result, a lot of the work that's been done around education and the management of the amount of exercise that they're doing, sort of, if you want to use the term load management, we will, as much as I dislike it, that seems to be the way to go for the majority of adolescents. If you give them good education, give their parents good education, and moderate the amount of sport or sports that they're doing, that seems to be the most effective thing you can do for the average adolescent. And then if you sort of move up a level and go into the adults, whether we're thinking about military recruits or runners or someone with day-to-day symptoms, certainly what Simon and I present is that this is going to be managed by manipulation of either the way that you're moving, whether that's your muscle strength or whether that's actual movement patterns, some modification of that, whether it's the amount of stuff you're doing, and again, that's where the load management side of things come in, wrapped up then with paying attention to some of the more psychosocial variables, if that seems to be what's really strongly coming out from within that assessment. But normally for the average patient, certainly for me at least, there will normally be an exercise intervention coupled with some form of movement retraining if required, alongside some education and some management of the amount of whatever activity that patient is looking to be able to achieve, whether it's running, whether it's gym work, whether it's basic military training, etc.
Yeah, that specificity I find interesting, because it's individualized specificity depending on what you've found. And of course, that's why we'd need to unpack case study to really understand the specifics and the dosages or, the response rate. And especially what we would find in clinic is that you wouldn't necessarily do all of that all at once, of course. So the order of play can vary. Simon, what's your take on sort of the you've mentioned about treatment and treatment directions and what the evidence informs in that. Where do you feel are both the current and future variables of treatment that you find to be most interesting for us to then think of? What do we get good bang for our buck for now, and what do you think is going to be a future line of direction for us to care better for these patients?
I think what Brad's touched on there is absolutely central to the core management approach, if we like. That's where the evidence kind of sits. That's where the evidence is going to evolve. I think that there are some bolt-ons, if you like, to that, which are extremely useful for the right individual at the right time. The taping as an example, foot orthoses as an example, knee braces. I've been involved with a study that was done out in Brazil that looked at how a knee brace affected an individual's kinesiophobia. So, sort of that aspect of whether it's pain derived or whether it's just centrally derived in terms of somebody's unwillingness or want to move because of their knee symptoms, which is very impossible to separate that. But the knee support, just a simple neoprene sleeve, had a positive impact upon that group of individuals' willingness to move. So adjuncts in that sense, orthoses, taping, bracing, etc., have a role to play. And I think that there is some work still to do to understand the mechanisms through which those given adjuncts are having their positive effect, because then that enables us to identify characteristics within a given individual as to characteristics which may well result in a greater treatment effect from any one given adjunct. So I think that there is some fairly robust evidence to suggest that those things can have those types of interventions can have a positive effect. In whom that they're most likely to have their greatest effect is work that is ongoing. And our colleague Mark Matthews has just recently published one of the largest RCTs looking at trying to stratify individuals by midfoot width difference and looking at orthoses versus a hip intervention. And that measure, that midfoot width difference, as a means to stratify between those who are more likely to have a beneficial effect with an orthoses against a hip intervention, didn't look to have a stratifying property, if you like. So it couldn't help you to determine whether they're more likely to be beneficial or have greater benefit from having an orthoses over a hip intervention. But that aspect, mechanism of effect, and in whom they're most likely to have an effect, is where I think the evidence will continue to grow, because we've got these treatment adjuncts that are effective. Beyond that, I think that then within exercise intervention itself, there's huge scope to understand better how these given interventions are having the positive effects that we're observing, and are there a group of individuals for whom they're more likely to have a positive effect. And then, as Brad has really started out with his PhD, and as many of our colleagues around the world are looking into, is this aspect of movement retraining that has predominantly resided within the running group for now. But I think that there is scope, obviously, for that particular retraining approach to emerge within stair stepping, etc., and trying to understand what role interventions directed at that given movement pattern can have. So exercise specificity, loads of scope. I mean, we could go on, we could do another podcast on that easy, Jack, but sure, in terms of sort of, how can we understand better what through what mechanism these interventions are having their effect? How specific do we need to be? Is global good enough? Do we need to really target neuromuscular activation? Do we then go into strength endurance? Do they need that in order to be having the greatest effect? Do we need to take them into strength and into power domains in order to really elicit the kind of muscular change that we think is critical to not only these short and medium term effects as we're observing, but out into the longer term? Fukuda led on an RCT a good few years ago now that really took their cohort, took their patients into strength training as sort of the strength and conditioning literature would suggest it is. They're working into 70% of their maximum efforts. They were pushing it into some degree of discomfort. They had a 1-year follow-up, and in those individuals who exercised their hip and their knee, they had a good longer term, 1 year is longish term, but longer term treatment outcomes. So, yeah, I think that's where it should go. I think we can really lean on some of these sort of the strength and conditioning literature or principles, I suppose, and applying them to a patient population and really exploring what is necessary in order to not only bring about short, medium-term effects, but longer term effects too.
One of the reasons that I end up being such a nerd for mechanisms is because of the fact that the management ongoing is often the big challenge, and you've identified it here with PFP, is that for us to try and work out how to sustain outcomes rather than just make somewhat transient, even if those transient changes are 6 months, so how can we make sure that this then the benefits of someone having some sustained gains would be huge on the system, especially in times like these. But when we think about the interventions that you've described, both in terms of the mainstay as well as the adjuncts, I want to come to each of you with an example in which I've just wondered if we could sort of flirt with the idea of what your take is on the mechanism, because I think it will matter. So for you, Brad, you're certainly well qualified for this question, having it been at the heart of your PhD. But with regards to run retraining, say you've had a patient who's got PFP that then has had a run retraining style intervention where you've made some sort of, through whatever mechanism in this instance, it can just be you've changed some of their cueing and they've changed their cadence or their pattern, whatever it might be that's changed, and their symptoms have taken a positive turn. They're then 80+% better and are then shaping up for discharge. In terms of what you think the mechanism of that intervention as to why that has alleviated symptoms, that really matters to what advice you would then give them. You bump into them in the street 3 years on. Are you still suggesting that they run that way? Is that something that should dip into and out of when they might develop symptoms or their symptoms worsen? Because the mechanism of effect of that intervention informs that ongoing care, in my opinion, which is why I always end up in that as my hobby horse. So wondered if I could throw that to you and say, what's your take on that matter? And also, how do you manage those patients, which I know you see every day?
I mean, my bias is certainly that run retraining as an umbrella, and again, a little bit like exercise and some of the other interventions, we've got a multitude of cues that seem to work, whether we're manipulating someone's foot strike, whether it's their step rate, whether it's their trunk position, whether it's trying to modify hip and knee kinematics, they all seem to be effective. And sort of at least to the very low end of medium term, kind of upwards of 4 to 6 months. So my thought around the mechanism is, and I'll be strong because I know you want me to be. For me, the mechanism of that intervention is mechanical. We've used a cue or a set of cues, whether in isolation or wrapped up in a multimodal intervention, but we've modified the forces going through that knee. And as a result, my bias, even though no one's gone out to 12-month follow-up on beyond, would be that chances are we need to try and maintain that net mechanical change in order for that intervention to be effective in the long run. So if we think about step rate retraining, increasing cadence, interchangeable term, we do that at a constant speed. It's done on the treadmill, and if we take a greater number of steps at a constant pace, we're going to manipulate the amount of force going through that knee purely because we're reducing how long that person is in contact with the ground. The external moments acting on the body are lower. And as a result, irrespective of what happens in terms of kinematics and the geometry of the joint, because we're modifying the force going up through the knee, theoretically we're manipulating joint stress. So my bias would very much be that the mechanism of that intervention is mechanical, and it's probably something we need to try and maintain.
Do you think you've corrected a fault in that?
I don't necessarily think fault's the right term personally, but I quite often have this conversation with patients in that we don't tend to see a lot of elite runners that get typical running pathology. They don't tend to present with PFP. They don't tend to present with ITB pain, etc. And the reality is when we manipulate, particularly when we manipulate step rate, we're trying to give that recreational runner a gait which is more akin to an elite runner. Yeah, the kind of colloquial term is overstride, and elite runners don't overstride because it's inefficient. It's a very inefficient way to run quickly for a prolonged period of time. So I don't necessarily think fault is the right term, but maybe in trying to reduce the force going through that knee, we're making this person's gait more efficient. And if we can maintain that into the long term, that's likely to have benefits both for their knee pain, but also for their long-term running efficiency.
If we understand, based on the conversation we've had on this podcast and many times before, that the biomechanics or running form in this instance is one of several variables that could have just culminated in them becoming symptomatic, and therefore the intervention of changing their running form in this instance has helped make them asymptomatic, is the argument not that you've got them out of symptoms and therefore they can phase back to running how they run, whatever that might be, because the other variables that contributed to their symptomology may well go unchanged because of the educational management and other factors that you've done, particularly if this isn't a singular care treatment, especially in a clinical environment rather than a research one. You may well have given them and counselled them on load management, sorry to use the term, Brad, as well as then some strengthening potentially interventions. Could it not be then, it just seems overcautious to me, especially if it's a very thoughtful running strategy, for that to be suggested ongoing?
I think that's a fair argument. And I think, again, you can almost make these decisions based on the individual patient. And if someone is only getting running-related symptoms, significantly more likely that I will be interested in and end up manipulating their gait. Whereas if we're dealing with someone who's getting symptoms in the gym, they're getting symptoms on stairs as well, they've stopped running and they're still symptomatic day to day, you're then much more likely to wrap that up around some exercise-based rehab. Every patient gets education. Let's not kid ourselves here. But so those patients, definitely, it's going to be a lot more multimodal. And as a result, what do they need to do long-term? Is it the day-to-day stuff that means they're not tolerating running? Is it the running that's leading to the day-to-day stuff? I think that's that clinical reasoning that we keep harping back to, and that's how you piece it together. And arguably, even if someone just has running-related symptoms and we deliver a run retraining intervention, chances are we're still going to be talking around how much running we're doing in any given week. We're going to be talking about intensity ranges and progressing gradually based on a percentage or something like that. So I'm very open to the fact that the mechanism is likely to vary across a cohort, and as a result, the long-term strategy required is likely to vary as well. But in the short to medium term, the sort of gross effect of the intervention comes about as a result of manipulating force. And we can't see force, and that's why people are often uncomfortable with it, I think. And
I want to try and play something. I won't go to the adjuncts necessarily in this instance, Simon, because I think it's smart for me to just try and use a similar example with regards to strength, be that glutes or quads or both, sod it. Let's just think of it as a strength intervention where potentially in someone that we've not necessarily known for it to correct a deficit, this is where I said we'll come back to, is that there is an argument that when you've assessed someone to find that they've got a deficit, say that to the contralateral side, or if you're doing that to an age match control particularly, or whatever it might be, that we feel that is low, you then are somewhat correcting for that deficit or altering that deficit by way of treatment, and that has then correlated with a symptom improvement. With regards to then that ongoing, the mechanism that you perceive has been at play in helping resolve that is going to mean it's going to really alter the way in which you suggest ongoing management for this patient that you might not bump into for many years or ever see again. So what do you think is underneath that when we do a strength-based intervention that alleviates symptoms? What do you think the key mechanism is at play? And what advice are you giving for someone with regards to maintenance of that ongoing?
Yeah, I think if I situate myself firmly in clinic with this, and we've taken an assessment at baseline, we've intervened, we've seen a change in that symptom. So we've observed something at baseline, we've intervened, we've changed strength, as is this example, and we've seen an improvement in symptom. The conversation I'm then having with patients at this point is to say, look, we've changed your strength, which has had a positive effect upon changing your pain. Now, whether that's because you've actually got stronger, or whether that's because actually we've had a systemic effect by that strengthening intervention, which has reduced, increased the endorphin release, and that has a positive impact upon your pain. I couldn't tell you, but the conversation there that I'm having with the patient is that what's going to be critical is that we keep you in this higher strength zone, if you like, plane, and I often have a conversation to say that I don't know 100% what's going to be the ratio that's critical for you in order to maintain yourself in this state. It could be that for your twice a week running, we've got to maintain one session of strengthening or loading in that particular way in order to keep you symptom free. It could be that running in itself maintains you in a physically capable state, which means that you're going to be without symptom redevelopment. So it could be a 2-to-1 ratio, it could be that we need a 1-to-1 ratio. But I'm having these conversations, and I think as I emerge out the end of treatment with an individual, I'm trying to scale it back. I'm trying to pare it back to the minimal amount of input that is required in order to maintain themselves within that symptom state. And I think I have that very open conversation with patients quite early on through these sort of phases. And I say early on, it's onto the sort of 6 or 8 week period. We've done this intervention. We're starting to observe some strength changes as the example. And we're seeing an improvement in symptom. I'm saying, right, okay, well, as we start to exit out of your intense rehab period and we're looking towards the long term, in order to keep you able to run pain-free or keep you able to play hockey pain-free or whatever it might be that is their activity, we're going to need to try and establish what is going to be your minimum dose that is required in order to keep you within that pain-free state. And that's the conversation that I'm kind of having. Does that answer that question? I hope it does.
Yeah, it does. I know it definitely does, but because I'm me and because I like you both, I'm going to hold your feet to the fire. So on this instance, there is a patient that comes in that's a runner, recreational runner, who on assessment, you've found many different things, but let's just go for 3 key variables that you've found that probably seem relevant to the development of these symptoms. It coincides with a change in load, as well as the fact that he put on 1.5 stone of weight over Christmas. And you've also noticed that there's a strength deficit relative to contralateral limb and what you'd expect of age match control, being aware of those sorts of variables. But it's weaker than you'd expect it to be. Let's just go with those 3 things. Then a strength intervention, as well as probably counsel on the other factors, then make him asymptomatic. Then when there's been, say, the weight's been lost, the load management lesson's been learned, the understanding of the condition has increased, as well as then his strength has increased, and he's high-fiving you as he leaves the clinic room. When it comes to him as a recreational runner who loves to run and hates the gym, the fact that 3 times a week strength training has helped him get out of that, where are you allowing him to taper that strength training off completely? Because fundamentally it could well have been that this was just a perfect storm between those 3 and many other factors. Or is your gut telling you that actually that strength deficit is probably what we understand from the evidence as being actually core and central to this? Therefore, be careful not to taper that down too far ongoing, otherwise I'll see you in a year.
I mean, I have that conversation quite frankly with them, and I present that back to them and say that it could well be that this was a perfect storm, and actually you've done a cracking job at addressing all of these variables. You go forth and run, and you may well find that you are fortunate enough that the running itself maintains you in an optimal state of knee health, and you're good and you're off and away. But I'm not presenting that in that kind of binary fashion at the very end of treatment. I'm phasing that out as we go through, and often what I'm finding is we get to a ratio of 2-to-1, or they've lapsed for couple of weeks until we've followed up again, and actually, my knee started to grumble a little bit, and you go, okay, well, how much of that loading have you been, those exercises have you maintained? Oh, actually, no, I've sort of dropped away because I've just been enjoying running. These are the kind of conversations that I'm pretty confident we're all having, you go, okay, right, well, there's obviously a ratio there that is going to need to be maintained. There's obviously an amount, a dose of that exercise intervention that's going to be needing to be maintained in order for you to keep yourself in a state of knee health. And let's try and figure out what that is. And for as long as you want to be running and be running pain-free, which was our objective at the start of treatment, etc., it looks like you're going to need to be maintaining a 2-to-1 ratio. That's your choice. That's now, it's on to you. I've given you the tools to be able to do it. And it looks like we've learned through this journey that that's going to be what is required for you to stay in a state of symptom-free knee. That's how I'm presenting. It is very much that shared experience with the patient that's in front of me. I don't know if you're different, Brad, in terms of how you.
No, very, very similar, and I think it's why the education piece is so important. And this is why, I've said it a few times, I don't like load management. I don't like that term because I don't necessarily think we can define what it means. And I think education falls under the same umbrella, because everything we do to a point is education. And if we think about that particular example, the conversation I would be having with that runner as they start to perhaps titrate their exercise dose down because their symptoms are much better, that's when I'd start to bring in education around the fact, well, if we look at the average elite runner or the average sub-elite runner, they don't just run, and they do cross-train, and they will spend time in the gym, or they will use the swimming pool or something like that. And it may be that you need to go after some education strategies in order to maintain the level of compliance that we need, or that we observe that we need long term. I think that's kind of the key bit. We don't necessarily know that we need it until we take it away, because these long-term effects aren't particularly readily studied. And the reality is, and Simon and I are perhaps not that dissimilar outside of the fact that we probably see a slightly different cohort to most, it's not that easy to hang on to people long enough in order to observe these effects. Normally, patients get better enough for them, and then they're gone. And the challenge of the communication and the education is around hanging on to that patient long enough so that you can continue to do the job.
Yeah, absolutely. No, that's great. Thank you for that, for both those answers, really. I know that they are, I'm giving a false sort of sense of a case study that doesn't exist, but it's something that hopefully were fairly typical and useful for patients, for our listeners, to understand that these things are multifactorial in terms of the contributors to the circumstance that they find themselves in on diagnosis, but also then if we're going to use multiple different strands to our care, as is the nature of a clinical interface, then you sometimes struggle to tease those out. And it's one of the reasons why I think it might not have to be first, second and third, but the mechanisms of effect are something that are relevant for our understanding, because they can inform our management, especially in a condition where that ongoing management does seem to be the crux of where we want to really improve. Then thank you for entertaining my questions in that direction, gents. I really appreciate it. Now I want to just see if we can wrap this up then by you guys giving either a hot take on something that you feel we haven't necessarily touched on in this conversation, but also give us an indication as to how people can find out more about you.
Yeah, thanks. I think I'd like to pull it back around to almost where we started, which was, as PFP, the lower back pain of the knee, really. And why I want to bring it back around to that is because I think what we've touched on here is that the clinical skills that physios and other healthcare professionals have got, this ability to listen to people's stories as to what's resulted in them coming to clinic, your assessment, your objective examination skills, which help you to start to try and understand what we think are the drivers or the deficits of this person's presentation and persistence of symptoms, remain imperative. And that's imperative in lower back pain populations as it is within patellofemoral pain populations. So I see that skill set that we've got and that we're working hard to develop is absolutely central to an effective sort of forward progression of an optimal management of this patient population. The work that we've done, probably the work that I'm most proud of at this moment in time, which brought together a lot of my thinking through my PhD, etc., was this masterclass that we published with Brad's help, with Christian's help, with Danilo's help, in physical therapy and sport, because that really, for me, brought together a lot of this thinking that we've got here, trying to blend evidence into and really put it into a clinical practice environment in a meaningful way. And within that, we talked about what we thought were these predominant drivers. Do we think that there's a structural element? Do we think there's a biomechanical element? Do we think there's a load, volume, frequency, intensity element? Do we think that actually there's a predominant pain mechanism component to why this individual is presenting with symptoms? And it's from that then we have this more targeted or more focused approach into a way in which we're going to try and manage this individual. Are we going to manage them predominantly through an optimal educational load management, as we've kept talking about, but through that approach, are we going to really concentrate on trying to address some strength deficits, some movement pattern deficits? Are we going to use adjuncts in order to facilitate that pain reduction and optimization of the person in front of us? So that steered a lot of that thinking. That paper tries to summarize that. So I'd love readers and listeners, to go on and read through that paper and see what their thoughts are on it, and see if that helps them in their reasoned approach to the management of these individuals. And Brad and I have got an exciting paper that we're working on at the moment, which is an extension of our previous best practice guide that I was involved in a few years ago with Christian, and we're working on an updated version of that as we speak, and we're really excited about what insight that's going to bring in terms of the management of people with PFP. So, yeah. That's
fantastic. And if Brad, you were accused of having a PhD in caveats, then I will accuse Simon of having a PhD in nuance. So I don't know if I think both of those you'll happily wear as badges of pride, because in this conversation people are fishing for simplistic answers in a complex way and complex world, and I'm glad we've been able to wade through that together. Brad, what's your final take, or and also what other things would you like to divert the listeners' ears or eyes to?
I mean, I think my main takeaway for so much of this and what very much changed my thinking going through my PhD process is we'd all love the world to be black and white. Everything would be much easier. Medicine would certainly be much easier if it were black and white. But the reality is we spend so much time in the grey. And what I really don't like seeing is clinicians or even academics dismissing variables out of hand when we haven't fully explored them yet. So what I'd encourage people to remain is open-minded to the things that we don't necessarily know enough about yet. And for PFP, that's pretty much everything, whether it's imaging, whether it's biomechanics, whether it's how we treat it with exercise or any other intervention. Just remain open-minded to the fact that there are things we don't know. Yeah, let's think about risk factors. Whilst we didn't identify many risk factors, we've got a good understanding of what's not a risk factor. So we didn't say this earlier, but sex, for example, male, female, does not predict. Q angle does not predict. Age, height, weight, BMI, these things don't predict. So we're there for a lot of these variables. I think we can be fairly comfortable what doesn't matter, but we don't necessarily know yet what does matter. So what I really don't like to see is things being dismissed out of hand when actually we've barely scratched the surface. And hopefully from a treatment perspective, as Simon said, we've fortunately just secured a grant from the private Physiotherapy Education Foundation, to whom we're very thankful. They've funded a lot of our work to date, and we're very grateful to be working with them again. But we're trying to upcycle this best practice guide. So we're going to have a mixed methods study where we take a systematic review and meta-analysis, which is going to consist of well over 100 RCTs. So we should have some nice chunky statistical outputs coming. But we're then going to be interviewing both expert clinicians and service delivery champions as well to see what they think about this systematic review. And then we're also going to be interviewing a big group of patients who have had symptoms and also received treatment within the previous 6-month period. And then we're going to upscale or downscale the level of evidence based on how well these things line up. So what we're hoping from that is we'll be able to have a really strong output around something like exercise. Does it have efficacy? For whom? And how is it best delivered? And then what does that mean to the patient? And we're going to try and line as many of those things up as well. So it's sort of hopefully a fairly large and exciting project. And I'm hoping to be in a position to share some early data in the lower limb positium in 4 or 5 weeks' time, whenever it is. I don't have a diary at the moment because I don't have a huge amount to do being on clinical furlough, but I believe it's in around 5-6 weeks' time.
That's right, yeah, 26th of June. Good plug there, Brad. Well done. No, that's brilliant. I'm really looking forward to that. I think one of the things around the sensitivity of us to making sure people don't dismiss variables out of hand, I think it's a really good point. But also, we've got to try and find a way to recognise that sometimes people are being or coming across dismissive because they are saying that people are over attributing. So it's like there's a balance there. There's people that are dismissing it out of hand, and we shouldn't have any real time for them because they're doing so clumsily. But then the people that are over attributing our variable and it being their favourite thing that they want to infer causation to, those two camps just end up squabbling. And it's the fact that they're both wrong, and that we need to sometimes make sure we find a balance to directing our ire at both sides of that spectrum sometimes, to recognise that we're not saying that these things are, we're not avoiding dismissing them because we think they're super important. We're just saying that we haven't got evidence to dismiss them out of hand. And it's that we end up talking past each other, I think, a little bit on that. And it's a shame, because as your work has continued to show, it really should be about, let's look at this rich mosaic of a person to understand the behaviour of their condition, as well as the mechanisms in which, or the care delivery that is going to hopefully get them out of this problem. And we need to understand all the different variables. And so, we need to make sure that one thing doesn't overwhelm that conversation, but also that there's plenty of other different factors affecting it. So thank you so much as ever for the caveats, the nuance and the balance that you always bring to these conversations. It's absolutely brilliant to have had a chance to chat to you at length about it. I'm sure we'll speak again both on and off mic. Brad Neal, Simon Lack, thank you for coming on the show.
Thanks very much for having us.
Thanks, Jack.
Cheers, guys.
And that is session 78. Massive thanks to Brad and Simon. Hope you guys enjoyed that as much as I did. Absolutely brilliant chat and so much to take from it. Thanks again to Rehab My Patient. So go to rehabmypatient.com/Physio Matters for your free trial of both exercise prescription and telehealth virtual consulting software, all integrated on the cloud. Do check that out and support our sponsors who are making all this happen. Also, if you want to support us and you also want to gorge on the best MSK CPD event we could come up with at a time where we think we all need it most, therapy-live.co.uk. Register for free. A massive amount of content available across 9 concurrent streams, so please don't miss that. 12,000 people have already registered. There's certainly going to need to be a cap at some point. If we start breaching 20,000, then that is a bandwidth ask that is far beyond what we can afford right now. So please do join and make sure you don't miss out, especially if you're a regular Physio Matters listener. I'll be gutted if you miss that. So please do check it out. And we'll see you at that event. And of course, see you with future podcasts coming soon. All right, take care. And all that's left is the cheesy sign out.
You've been listening to the Physio Matters podcast.
Discussing Physio Matters.
Because physio
matters.
Lovely. Perfect.